I'm here with Barry Schechter. Barry, with patients with cataracts and even with patients with contact lenses, I'm a big fan of monovision. Now, when we talk about monovision, what we're talking about, of course, are just spherical lenses. You are not advocating monovision, but you're advocating an interesting strategy with multifocals that can do a lot of what monovision does, but still preserve binocular distance vision. Can I get you to sort of flesh this out, what you spoke about, and then I'll have more specific questions for you.
Thanks for having me, Josh. So basically this came about because there's really no trifocal lens implant that's available in the United States. When we claim to be putting in a multifocal lens implant, what we're really doing is putting in a bifocal lens implant. So in an effort to try to increase my patient's range of vision and make them more spectacle independent for distance, intermediate, and near, I decided to mix lower and higher power add multifocal IOLs.
Now, when we do monovision, typically, with the exception of some patients whose circumstances are not worth mentioning, we'll put the distance lens in the dominant eye, and the non-dominant eye gets the reading lens. Are you doing something similar, that you're putting the higher add lens in the non-dominant eye, or is there some other strategy that you're employing?
No, I'm using a tried and true method where we're using the lower power add in the dominant eye and the higher power add in the non-dominant eye. Specifically, we're using the Technis Multifocal ZMB and ZKB, which is equivalent to a 2.75 and a plus 4.0 reading add.
Now, what some surgeons do with, not with this strategy, but with multifocal lenses generally, is they'll assess the patient's function after the first eye is done. Do you modify your plans based on that? I mean, let's say that you've done the dominant eye first and the patient says, hey, look, doc, reading's just fine.
We do that. We have done that on occasion, but usually the patient has planned with us on how they want to go. They have different needs for different reading ads. Some of them like to work on computers or on tablets. Some of them are artists, so they want to have a little bit more intermediate range, and others are more used to doing close-up work like model airplanes. So we kind of select the patients that really want to have the increased range of vision and try to go with it that way. Although, as you said, there have been some modifications along the way.
Yeah, well, you'll want to be a little flexible.
Of course, patients to be happy.
But now, to be clear, I mean, because I've used the word monovision a lot here, you're aiming for plano with both eyes, though.
Yes, plano for distance, exactly.
Good. Are there patients who especially benefit from this strategy? Are there patients for whom you would not advocate this strategy, for whom you would still advocate multifocal lenses? I mean, obviously, there are patients who are not candidates for multifocals.
Right. Aside from the medical reasons or the physiologic reasons for people not to have these multifocal lens implants, personality plays a big role. If you have the type of person who's extremely type A, who will really close one eye then the other to compare the different focal distances, probably not best for them.
Yeah. Well, this makes complete sense, which is always convenient. I want to thank you very much for bringing this strategy to us and for being so very generous with your time with us today.
Thank you for having me. It's a pleasure.